to just thank the section for the opportunity to present this work and really acknowledge the great efforts that Charlie and Patrick have made um, to put this data together. Just by way of introduction, really what we're trying to understand is what organ shortage really means at a deeper level from that used at the common discourse level or in the opening paragraph of a paper. So with that, I'll hand it over to Charlie and or Patrick.
Thanks very much. Thanks everybody for having us.
Thanks, Jerome.
My name's Charlie. I'm just gonna, I'd love to share my screen, but sharing is not turned on. Is someone able to
try again in just one tick?
Thank you.
Should be working now.
Excellent. Yeah, perfect. Thanks. Are you all able to see this?
Yep.
Great. All right. Patrick, after you.
Fantastic. So good evening, everyone. As I mentioned, I'm Patrick. And Charlie and I have been working on this for our medical school program. And it's an international comparative analysis of liver transplant systems and an assessment of unmet need. And we've been doing this alongside Jerome at RPA. So I'd just like to begin by acknowledging the traditional owners of the land on which everyone is joining from today, and pay my respects to elders past, present, and emerging. I personally am joining from the Eora Nation. Charlie.
Okay. Yeah. So I understand that this background might be a little less relevant with the current audience, but I'll go through it anyway. So the liver transplant is an essential therapy for anybody with incurable end-stage liver disease. And we find it particularly interesting because it relies on the allocation of a very scarce resource, that being viable organs. And I think it's well known that demand exceeds supply. I think that's axiomatic, but the true imbalance between supply and demand is actually very difficult to quantify. And it's partly because of the way the system works. And this is a bit of an illustration. People with end-stage liver disease can be referred for evaluation, and if eligible, might make it onto the wait list, and then they are allocated an organ in a manner to reduce mortality on the wait list. And so you might think that the list would be a good measure of demand, but in 2015, in the US, there were 65,000 deaths due to end-stage liver disease, and only 10,000 patients were actually waitlisted, which is a pretty big difference, 55,000 patients. And some of it obviously is because, you know, many of them might not be eligible. There's other reasons behind this as well, but it just serves to highlight that the waitlist might not capture all of those who are in need and are eligible for a transplantation. But most research considers the waitlist as being proxy to demand, and then consider mortality on the waitlist as being a measure of how well the system can meet that demand. But the waitlist consists of patients who have been recognized by the liver transplant system as being in need. And so using this as a measure of demand assumes that the system has successfully identified everyone in the community who is in need and is eligible. And our research has shown that this might not actually be a very accurate assumption. And we thought that, you know, if you wanted to have a look at how well a system is performing, we would need to have a look at how it is interacting with the community. And we wanted to try and quantify unmet need beyond the waitlist, or, you know, at least confirm that it exists. And this is important because of some of the things that we were talking about before this even started. You know, because the organ supply is not actually fixed, it's elastic, and it can be improved through things like machine perfusion technologies, live donations, extended criteria donors, but only really if policymakers are incentivized to do so. Understanding that demand exceeds supply, and that imbalance might be greater than we think, that could form the incentive.
So, as Charlie's mentioned, the waitlist and waitlist mortality are often used as metrics of the performance of a liver transplant system, and this tends to be in a contradiction to as he mentioned, an axiomatic view that supply is way outweighed by demand. As such, thinking of it as using it as a metric of the performance, we think of waitlist mortality as a direct measure of the deficit of the transplant system with respect to eligible patients only. Importantly, no jurisdiction has zero mortality on the waitlist, but there is significant variability between jurisdictions. And that begs the question of whether the variation is just due to variations in supply and demand, which tend to be fairly stable, or whether it's due to some other function or functions of the system. And that is what we've termed as producing the willingness of the system to list patients above capacity to transplant. So what is the current situation in Australasia? Well, we don't have very good idea about the underlying prevalence of end-stage liver disease due to the lack of consistent regulated data collection. Australia itself performs around 300 transplants annually, and that's achieved without using methods to increase donation capacity, such as live liver donors, extended criteria donors, or modern organ preservation techniques, which are commonly used in other jurisdictions to improve the supply of organs. Partly the reason for that is because of the ability of Australia to perform well when compared with other countries and their waitlists. We have around half the waitlist mortality of the United States, which looks pretty good. But it really does beg the question of whether this is an accurate representation of the situation in Australia.
So we decided to ask ourselves, for the purposes of this research, can we show that there is need within the community that is unmet by the liver transplant system? And importantly, is there need beyond the wait list that's unrecognized? And we wanted to do this, with a two-front approach. We wanted to understand what evidence existed on the matter, and then we wanted to try and contribute to this evidence by doing something we didn't believe had been done before. And so we went through a review and a meta-analysis of the current research, and then we separately did comparative and statistical analyses, which we'll explain in time. But the meta-analysis, we applied a broad list of search terms to Medline, Scopus, Embase, and we looked for articles which tried to quantify demand beyond the waitlist. We used this exclusion criteria to systematically exclude articles, and we ended up with 13 articles we thought would try and quantify that demand beyond the waitlist. And we looked for some key metrics, specifically referral rates, waitlisting rates, and transplant rates, and any other metrics we thought were useful and pertain to this study. And then we did separate statistical analyses. So mine was on the study of the correlation between organ donations and the number of liver transplants, and then disease prevalence being decompensated cirrhosis and the number of liver transplants. And this is done at a country level, and these correlations were studied and compared. The disease prevalence, decompensated cirrhosis, was our measure, our proxy for demand, as it's the biggest indication for liver transplant. Obviously, it will never numerically match true demand within the community, but it should be well correlated, and so these correlations still become informative. And we wanted to see really if the global liver transplant systems were supply driven or demand driven, and the implications of that we'll talk about a little bit later.
And the analysis that I performed was looking at the wait list versus demand, again, using publicly available data, the Lancet Global Burden of Disease study from 2017, and the corresponding annual waitlist reports. They did prove to be fairly difficult to find, but ultimately we found reliable English language reports from these 17 countries, mainly North America, Australasia, and Western Europe. So this is the from the systematic review. It's just a brief summary. It's quite a busy summary, really, of the targeted outcomes in the studies. But importantly, in the middle columns are the referral rate, the listing rate, and the transplantation rate. And Charlie will go into a little bit of depth with these.
Yeah, so just a highlight reel, I suppose, from the meta-analysis. These three metrics we pulled out from the 13 articles that had them in them. And referral rates, waitlisting rates, and transplant rates are the rates of their study populations being referred, and then their study populations being waitlisted, and then their study populations ended up being transplanted. And the study populations were all heterogeneous, but they were all an attempt to capture eligible patients beyond the waitlist. So some might be people with end-stage liver disease who are admitted to a certain hospital. Others were very specific, people with end-stage liver disease who were deemed eligible for transplant after review of their notes. But in terms of the range of results that we found, the best referral rate we found was 27%, and the worst was 0.8%. And it doesn't get much better. 28.6% was the best waitlisting rate we found, was 0.1%, and then 22.6% and 1.5% best and worst for transplant rates. And if we just take this number, the best referral rate we found, 27%, it implies that there could be as many as 73% of eligible patients who would benefit from a transplant who were never referred for that initial consultation. So the very first step in that transplant pathway, 73% potentially have missed out. These numbers surprise us. I think they're a lot lower than one might expect for a well-performing system.
And many of the studies also went further than just reporting an overall rate of unmet need. They also uncovered trends between subgroups of their study populations. And that highlighted disparities in access to liver transplant services. There's, they're listed there, but geographic, sex, ethnicity, whether people had insurance or not, or private insurance or public insurance, whether they were close to transplant centers or not, and of course, age. And it is interesting, but it serves to highlight unmet need further, really. So moving on to the comparative analysis that I performed for waitlist versus demand. We wanted, for this specific correlation, we used the waitlist performance, as we termed it, which was the waitlist at the end of the period plus the annual additions. And we compared that to decompensated cirrhosis prevalence, the estimate from the Lancet study. Of course, it isn't going to be a perfect correlation because not everyone with decompensated cirrhosis is eligible for a transplant, but we thought that it should be pretty close. But as you can see, there was no significant correlation observed. And we used another metric of demand as well, which was devised by Adler et al. From the systematic review, actually, which is the estimated liver demand. And that is the number of cirrhosis deaths in the population plus the number of transplants for that same period. So essentially a number of people that would have benefited from or required a transplant for that year. And again, we found no correlation to the performance of the waitlist here either.
So my work was not looking at waitlist. My comparative analysis was between deceased donors and deceased transplants. and then comparing that with disease prevalence versus total transplants, total liver transplants. And on the left, we can see that deceased donors and deceased liver transplants are very well correlated. So this deceased donors is not just livers, it's any organ tissue donated. And it came up with a Pearson's correlation coefficient of 0.908. So very strongly positively correlated. And compare that with disease prevalence versus total transplants, which is uncorrelated. So this does show that globally, the liver transplant system is supply driven and not demand driven. It does not respond well to demand. This fringe of patients who would be transplanted if the organs were available. And that implies that there must be unmet need in every jurisdiction, and that no jurisdiction can meet the true demand of their community.
Sorry, Charlie, can I just interrupt for a second? Just go back. I mean, just to make it clear to everyone, this plot is each dot is a country around the world. So each dot is a different individual country, and it's the rate of their deceased donation rate per million population versus their liver transplant rate per million population in the year 2017. So essentially, we're looking at obviously not every country in the world's included, but it includes many countries in the world, both countries which you'd consider not particularly developed, and countries which are highly industrialized. And that's true for both graphs of disease prevalence versus total transplants and deceased donors versus deceased.
Thank you. And then this last graph was not included in either of our projects so far. It's actually a combination of the research that we've been doing. But this is deceased donors versus the number of people on the wait list. And it is positively correlated. Pearson's correlation coefficient 0.767, so moderately strongly correlated. And it just goes to show that, as the donation rate goes up, as more organs become available, the trend is that more people are waitlisted. So the willingness to waitlist may increase as more organs become available, which just again shows or supports the argument that the liver transplant systems globally are supply driven. Again, each dot represents a different country. Now, this data is much more scarce than the previous graphs, because again, the waitlisting numbers were much more difficult to find than disease prevalence and organ donation in the year 2017.
And so where does that really leave us? Well, this is currently how we're keeping track of the system, with very little knowledge of the actual demand. Currently up until now, a lot of jurisdictions have deemed this adequate, but I tend to think that it's probably an issue not to look at the whole picture. So this is a slightly, wider view, but still overly basic, of course. And we do need to understand these two factors highlighted here in blue. So the referral rate and the listing rate, and understand their place in the creation of the waitlist, which is what we're currently using to assess performance. They really are the bridge from disease to transplant.
So just quick conclusion and summary. We found that the existing research suggests that there is an imbalance between supply and demand, and this imbalance is greater when we look beyond the wait list. And this imbalance is also exaggerated in certain subgroups, but certainly every article agreed that this imbalance was larger when we look at demand beyond the wait list. And then our own statistical analysis shows that on an international level, liver transplants are supply driven and not demand driven. And that essentially implies that no jurisdiction can meet the true demand of their community. And if you consider even just an example of two countries with comparable disease prevalence, but one country is less available, then there will definitely be unmet need within that community, within that jurisdiction.
And so, I mean, this study has shown that the waitlist does not reflect the need for transplantation, and that waitlist mortality does not accurately reflect the unmet demand of the system. And I think it's critical that we challenge the idea of the waitlist as it is currently operating as a measure of performance. And it's imperative that we, reframe our thinking of waitlist mortality and potentially become more comfortable with a higher rate. We need to look past the deaths on the waitlist as just deaths and more as a measure of the magnitude of the benefit that is provided by the system. And of course, we can just achieve this by listing more patients, but to what end? Because, of course, it is not free to list patients. An increase in waitlist mortality would give us a better understanding of the actual demand, and, of course, necessitates that increase in spending. But it surely would not be futile done well, because of having a better understanding of demand would give a greater imperative to transplant. And the greater imperative to transplant would give us a greater imperative to use any donation opportunities, whether they be living or improving methods around deceased donation, and using those opportunities well.
And I think that's
Thanks
it.
very much. Yeah.
Yeah,
Any
thanks very
questions?
much for having us.
Thanks, Pat and Charlie. They're really well presented. Thank you very much. And just would like to open the discussion to all the experts that are here with us tonight and try to understand what they think or get their perspective on the project.
Was this sort of your MD project, or was this something completely separate in addition to an MD project?
No, this is an MD project. We have individual projects, but I think the combination of our two projects will be a more complete picture. That will continue on. The MD project finishes this week, but we'd like to combine and potentially publish this work later in the year.
Okay. I mean, I guess the thing that struck me was that correlation between deceased donor rate and deceased donor liver transplants, it has to be a straight line, doesn't it? I mean, obviously, that doesn't surprise me. I wondered whether you had sort of been able to, I guess, sub-analyze different categories of liver disease, because there are many social factors why people don't get listed for liver transplant, particularly if alcohol is the underlying liver disease, and whether you had looked at everything other than self-inflicted liver disease, if you know what I mean. So had you looked at, say, the incidence of primary biliary cirrhosis and listing for liver transplant, and is that dramatically different than alcoholic liver disease, as an example, or liver disease secondary to hepatitis C? Because I think there are, either conscious or unconscious biases, but there are also genuine social reasons why you might not list someone. And I wondered whether had you been able to, or had you thought, or had Jerome discussed with you whether that was something that would be worth exploring further, to try and drill down to the different subsets of liver disease and the influence on that on listing, because I can see that there's huge differences between some of these patient populations, and you're suggesting that we're really not even scratching the surface or the tip of the iceberg of liver disease, whereas the counter argument could be that actually many of these patients are never deemed suitable, and I suppose we never know, do we? And just that was my thinking.
So, just to answer that question, we don't. The data is. You very rarely see a study which includes all patients in the world in a certain year, and that's basically what we've got. So obviously we've got very non-granular data. We just have, the classification of decompensated cirrhosis. But I mean, there are some other. You can have compensated cirrhosis. You can death from cirrhosis, but you can't have etiology level data because it's not collected at that level easily and easily available to us. So that's number one. Number two, so you raise a report. It seems pathology to correlate something which is completely dependent on something else. In other words, that the transplantation rate correlates precisely with the donation rate. How could it be else, right? But then think back to the rest of your argument, which is, well, there's all these complex mediators of liver disease and different epidemiology. But when you consider that no matter what the other mediators of the disease, no matter what the epidemiology in the country, no matter what else was happening, the basic determinant of liver transplantation is available organs. So if you've got available, all that means is that if you have available organs, you can find someone to transplant with some disease etiology, if you have a system set up to do it. And so then think about the other graph, which is we know that disease prevalence, decompensated cirrhosis is the main driver of transplant, right? So why? How can two things that we know should be related, the indications for transplant and transplants are completely unrelated. So two things which seem like they have to be related are completely uncorrelated. And the only answer that I can come up with to explain that is that within the available organ donation rate, the demand is completely saturating. So it doesn't matter whether your organ donation rate and transplantation rate is 10 per million or 20 per million or 30 per million, you're still not even touching the surface of the liver disease in that community. And so there appears to be no correlation. The rate of liver transplantation per million population may have to increase 10, 20, 30-fold before you'd start to uncover the relationship, the correlation that you'd expect.
I would just also throw in as well that during the meta-analysis, we came across a lot of articles that did look at that level of granular data and looked at different disease indications and different eligibility criterias. Some papers went as specific as reviewing notes and deciding whether or not someone was eligible based on their specific course through the healthcare system. And even with those articles that had such specific study groups of patients that they deemed to definitely be eligible for liver transplant, the referral rates even were never higher than 27%. So the meta-analysis revealed some
And so I guess the question comes to, so what? What can you do if demand exceeds supply? What can you do? Well, I think one important imperative is we can stop behaving as though listing is not important, because listing is critical. If we don't have a obvious statement of severe need, it's difficult to do things ethically to increase supply when those things imply technical challenges and risks for the recipients. In other words, the actual risk of discarding a 50% steatotic liver is not fully stated when you have a 5% death on the wait list. But actually, the 5% death on the wait list in Australia just represents a lack of listing due to other incentives and constraints in our system. So, the discarding of 50% steatotic livers is rational in our system, but it's not rational when you compare the choices that would be available to someone if they were listed. Santosh, you've got a question?
Yeah, thank you, Charlie and Patrick. I'm not a liver surgeon, but I found this interesting. The fact that you're saying it is supply driven, I get that. I mean, if there is no supply, then you don't have any organs to use. But likewise, if there is not enough demand, there is no point having a high supply because you're not going to use it. In fact, I was just quickly having a look at the Donate Life and ANS data on the website. And at this time, 2024, recent month, the waiting list in Australia is only 100 for liver. And the whole number of transplants is only 218. So there's no point having a whole bunch of org supply, because you're not going to have anybody on the waiting list. And that again, you did point out to your graph on the left side saying each one of those dots are each countries. Now, when you looked at Australasia, did you look at all the Asian countries like South Korea and those sort of Taiwan and all those, where the numbers are huge in terms of living donor transplants, and which is sort of very minimal in Australia? So how would that play into this whole equation of supply versus demand?
Yeah, I mean, we really want to look at a lot of the Asian countries. Actually, I guess South Korea, like you say, they have a unique supply. Very little deceased donor. It's it's by far the minority of their transplants is deceased donor. But we couldn't find a lot of, especially for the waitlist data. There was almost none that we could easily find, and especially none in English. So it made it very difficult to find that data for us anyway at this stage.
Santosh, I'll just take you back to one thing you said, which is if there's no demand on the wait list. And I think all I'm trying to demonstrate is that the absence of waitlist demand doesn't imply an absence of demand. It implies a failure of the waitlisting system. So, rather than interpreting that as a lack of imperative to increase donation, living and deceased, it's an imperative to improve listing. Because what you could do is you could increase listing. Think about the incentives that are required to make someone list, for example, at a center like Sydney, list, I don't know, 50 patients more than they can transplant. That's what it would mean to have a 50% mortality on the wait list. It would mean they have to bring them to clinic. They've got to answer their letters. They've got to generate correspondence. They've got to do echocardiograms on all of them every year. They've got to send them to cardiologists. They've got to do bubble studies on them. Like, the resources required to not transplant 50 people, to identify and not transplant 50 people who could benefit from transplantation, considerable. But then if you had 50 people on the deceased donor wait list, then you'd start saying to them, look, you're never going to get a transplant. Why doesn't your cousin come and donate? So that the conversation that gets someone to transplantation is perception of the real need.
There was also something you said about the live donations and considering live donations. The data set that we pulled this deceased donors from did have some information on live donors per country. It was less reliable and less well recorded, but it was also, we decided to not include it in this correlation study because one live donor of a liver will have one recipient patient. They tend to know each other, and it's, they tend to organize themselves, I suppose. And so it was more interesting, we thought, to look at deceased donors of any tissue type versus deceased transplants, because this isn't necessarily a one-to-one relationship. Someone may die and donate their organs and never know where they're going to go or if they're going to be used. And so we purposefully left live donations out of this particular study for that reason.
And you can see there are jurisdictions that have deceased donation but no transplantation. Like, there's 4 or 5 dots right on the bottom of the graph, which are, countries which just don't have deceased donor liver transplant programs, but do have transplant programs. So, and actually that's the major thing stopping the correlation coefficient from being 95 or 97.
So, is there any key things that you have identified as to how to increase this or have an incentive to increase this wait list from your study?
Yeah, not from our study. It's not possible to really clearly identify from the study, but I think it's pretty clear. So it's pretty clear from comparing categorically the United States and Australia. So the United States has the world's highest rate of liver transplant per population. It's higher than Korea, it's higher than Saudi Arabia, it's higher than any country in the world. It's higher than Spain. And what is it about the United States that makes them transplant patients at a high rate? And I would suggest that they have incentives to transplant patients at a high rate, and that happens at all levels. They've got incentivization of the organ donation system. The OPOs are competing, and they're competing, although they're generally not for profit. They're not for profit private organizations that are competing for the business. The transplant centers are competing for the patients, and generally transplantation generates a profit for the institution. So, I mean, and they've got a really important difference between Australia and, we generally don't have MELD-based competition or any kind of competition for organs. In other words, whether we have one patient on the wait list with a MELD of 8 or 6 patients on the wait list with a MELD of 20, it doesn't make a difference. As long as we've got one patient in that blood group, we can do a transplant. Whereas if you had competitive MELD-based listing, in fact, that's how the United States gets to having large wait lists. You have to have patients of high MELD on the wait list. Otherwise, you're not going to attract any organs, and you won't do any transplants, and your program will fault. So, the reason why we don't list patients and don't do transplants at the same rate. But by the way, the United States got a transplant rate 3 times higher than us, with a disease prevalence probably only 50% higher. So, all that's happening in Australia is that people with liver disease are just not able to access transplants as easily as they would be in the United States because of our system. Basically, because we have single jurisdictions, no organ competition, monopoly OPOs, and no incentive at an institution or individual physician level to do work.
Yeah, thank you, Jerome. In fact, I think this was alluded to at our Adelaide conference by one of the liver surgeons who had come down when he mentioned that as you mentioned, every hospital which runs a program is audited on a yearly basis, looking at their numbers and results and so on. And they are even shut down if they do not meet the standards and so on. So that sort of thing doesn't really happen here.
Well, it's actually a bit more subtle. So what I've described is the combination of incentives and constraints. So that's how you get a high death on the wait list. You have to have incentives to list patients, and then you have to have a constraint of outcome. At the moment, we have no outcome constraints. Literally no one checks the outcomes of RPA or the Austin or the PA and says your wait-list mortality, your post-transplant outcomes are not good enough. So if someone checks the post-transplant outcomes, then if you list a patient who's very high risk, or they progress to become higher risk than they were when you list them, you have to remove them from the list, which is the major source of death on the wait list. It's people being removed from the wait list for being too sick, which doesn't mean they're too sick. It just means they're too high risk to transplant for that transplant center, because when the transplant outcomes are analyzed post-transplant, they won't be adequate to maintain their accreditation with UNOS. So it's this combination of incentives and constraints within the United States that generates their high wait-list mortality. Whereas, at the moment, we have no incentive, literally in Australia, no incentive to transplant, and then no post-transplant outcome constraint, literally zero. No one's even monitoring the outcomes apart from Michael Fink, who occasionally looks at it and tells us, how we're doing, but there's no systematic consequence to that. Marcus, since I was wondering if I could touch on Marcus Perini and ask him where you think things stand in Australia. I guess my big question is, what do you think about competitive listing in Australia as a concept?
Sorry, Jerome, was that a question to me?
Yes, I was just sorry to interrupt you.
No, that's all right.
I'm basically talking about mechanisms to systematically increase listing, because we're talking about listing as though it's a conscious act undertaken by a physician, who doesn't do it because they're too lazy or can't be bothered. But actually, that's not really the way to think about it. We've got to think systemically about it. What is it that causes systems to list more patients? First of all, more resources to do it. But second of all, there's got to be some at an institutional level, at a personal level, at even the viability of the service level to maintain transplantation numbers and to provide some reason to list patients above and beyond the capacity that you have to do transplants. We know pretty well how many transplants we're going to do a year. We know pretty well how many patients we need to add to the list to keep the blood group A list from diminishing to nothing. So it's not like we don't know, but how do we get people to list more patients? And with that thing, then I think we can generate the imperative to really use ECD graphs to do like the Swiss do, like do a 70-year-old DCD 2-hour agonal time on a hard to justify the trouble and the difficulty. We've got no justification for pressurizing the hospital to make living donation a reality, because we just don't list enough of the patients who need listing.
So yeah, I think there are a few points that you raised that are quite important. So put patients on the waiting list is physicians driven. They put most of the patients there, and sometimes we have to ask them at least here and say, oh, hang on, does this patient needs a liver transplant? Maybe we should not. At the other end, we have a few patients that have been waiting on the waiting list for 1 year. Do they need a transplant, or can we take them out of the list because they will do better? And we already test the tumor behavior in this patient, and we know that they will not recur or whatever. So there is a bit of a disbalance there. And another point that you touch is, we are not America. In America, you have to do the transplants. So the units there, they run and they'll find the patients at the pub, and they'll bring in and they'll transplant the patient because they need to keep the machine running. Here in Australia, no, we are very, very selective, and we try to justify every cent that we're gonna expand in these patients. And finally, we as surgeons, I think, at least as far as I can get, we are a bit disconnected. So I know some things that you guys Sydney's are doing. I know some things that the guys Brisbane are doing, but we are actually, we do have these meetings, but we are not 100% together. So if the problem is, look at this, we know that normothermic regional perfusion is much better. So, and then we face, but there is a law. Well, can we, as a crafts group, work on the law and change the law and raise the point, at least say, you're wasting money because of technical reason or just a couple of wording. So it's hard. It's hard, Jerome. I think it's putting patients on the waiting list, and patients will come, and we're gonna have, and people are getting fat, and we are transplanting fatty people with fatty livers. When I don't remember the last time, apart from the kids that we do, apart from the kids, I don't remember any liver that's not an ECD liver.
Yeah, that's true. I think, but also, I don't remember a single liver that we've used that would have been used 15 years ago. They all would have been discarded, and we've used all of them, and they're all fine. So, I think that really brings the understanding of the fact that supply is elastic. When you really have demand, then you really stretch supply. And actually, the paradox in liver transplantation, which I hadn't observed it in kidney transplantation, when you use ECD kidneys, you get really bad outcomes. In liver transplantation, when you use ECD livers, you often get good outcomes, in my experience. And then I think you also made a point which I really described as creating a constituency. There is no constituency in liver transplantation. We're not a group of unified people who could make a political demand on anyone because we have no political supporters. We're not even a recognized entity. We wouldn't, if we were discriminated against, no one would come to our defense. Creating a constituency for understanding liver transplantation demand is also really important. Henry, sorry, put your hand up.
Yeah, no, it wasn't a legacy hand. It was a new hand. No, I think it's almost unsolvable, but I suspect it will slowly be solved. But when you see what's happened to our acceptance of the very sort of expanded criteria donors that, as you say, we never would have considered. Well, 30 years ago, I would have just laughed at you if you'd said, "I'll go and do a liver retrieval on an alcoholic," So I think what we've seen in deceased donation is a huge expansion into almost considering and wanting every patient referred as a potential donor. What we currently don't have is we have a tiny proportion of the people with chronic liver disease referred. Now that might be historical because the hepatologists, gastroenterologists are worried about the 1 in 10 mortality within 12 months. Maybe that's an issue, but I think probably they're more worried about having insufficient livers to transplant them. So you're right, it's that chicken and egg, until you chuck more people onto the waiting list, you won't ever push your numbers up or push the need for liver transplantation in Australia. It's a hard problem to solve. And just my other comment, you mentioned about the US. I mean, financially, the surgeons get paid handsomely for every liver transplant they do, which is interestingly a massive incentive for doing a liver transplant. And that's one of the reasons why pancreas transplantation has gone down, because they don't get paid for it. So I agree, they need to maintain accreditation. So they need lots of people on the waiting list so that they can use an organ and transplant it. But they don't want to have a poor outcome, and that would jeopardize their unit. But they do have a massive financial incentive, and I'm not sure that would be a good way to solve the problem. But maybe if they did pay us all, $100,000 for a liver transplant, we'd probably find more people on the waiting list. I guarantee you would. But I don't think that's actually the way forward. But I don't have a solution, Jerome, but I think you'll find it'll slowly increase. And, we are transplanting people with alcoholic hepatitis, and we're definitely transplanting people who are still drinking. And, it's amazing how we have expanded. We're transplanting people with, active malignancy. So I think the whole field is changing. So you will slowly increase the referral, but we also don't have the ability to cope with the referrals, do we? If what Charlie and Patrick have shown, we see a tiny proportion. The hepatologists couldn't possibly assess the number of patients currently. So that would be, the first thing, to actually invest in those facilities and staff, nurses, clinics, to actually see those patients, and just start for a blanket referral.
And this is surely the chicken and the egg, like you've described it, is so difficult to get to the beginning of that circle. And it has to start somewhere, because you can't list people without the funding, but you can't fund without the incentive to fund, which is potentially the listing. And I mean, do you not think that there has to be at some point a conscious decision made somewhere in that circle to change, rather than just letting it slowly get towards where you're going? Or do you think potentially that's the better way of doing it?
Santosh, is your hand still up, or is it from last time.
Now you mentioned about the external criteria donors in the kidneys. See, it was only in 2008 that we sort of slowly started doing ECDs, and today, I mean, apart from that first couple of years, after that, the graft function is pretty good compared to a DBD donor. And now today, I mean, I was just looking at our number, 63 something transplants for the and we also we have 22 DCDs for the year. In fact, a few months ago, I made a presentation, and we were like going half and half for DCD kidneys. At least in the kidney world, I think it's coming to a situation where one, we're getting patients who are on the third, fourth, and transplants, and everybody, and even the physicians are like, everybody is keen on getting their hands on a kidney rather than saying no to a kidney. So right from all sorts of organs, I think people are much more open in the kidney world to accept an organ.
I mean, I personally, like, I know we've sort of said there's no solution, but I think I'm not sure how long Australia can maintain single jurisdiction transplant centers, liver transplant centers. But New South Wales is now got a population double what it had in 1985, same as Queensland, and I think having no competitive listing is a real problem systematically, and is probably the driver. Because if you're gonna increase resources to list and assess patients, your choice is to increase resources in the existing center or open a new one, and you're probably going to get more bang from your buck for opening a new center, is my suspicion. And I think that's a really tough conversation, because everyone has to be uncomfortable. You've got to live with all the implications of having two centers. But I would point out one thing, which is Ontario is the only jurisdiction in Canada which has got two liver transplant centers, and it's consistently had a liver transplant rate twice per population of every other province in Canada. So I think we just need to more center of state is something that's going to be helpful in moving the dial.
We're gonna have to have a good chat with the administrators, because they're cutting our money instead of giving money to us.
No, that's right. I mean, I think part of it's about also, as you said, Marcus, creating the political constituency for what we're doing. If someone were to reduce funding for cancer services, you'd find support within the not just the general community. The general community, I don't think, feels that strongly about it. I think it's about having a constituency of politically engaged supporters for your service, and I think that's something we do have to work on. Henry, is that a legacy hand, or is it?
No, I was just thinking, in the renal world, you've got such hard data, and it's pretty easy to show, the patients that are on dialysis within Australia and New Zealand, and then the patients that are on the binational transplant waiting list. We don't even list 9% overall. So we know that 91% plus will die on dialysis. So you've actually got that as a bargaining tool, I guess. And I wonder whether that's really changed that much over the years. I think people have actually remained pretty conservative, funnily enough, about using kidneys. I'm always amazed when nephrologists say, "Oh, my patient's too well on dialysis." They're 62 and they're too well on dialysis to accept a kidney. But you've got that really hard data that actually supports whatever you want to argue. From what Patrick and Charlie have shown us, it seems a little bit vague as to where are the patients? Are they just being managed by their GP? Do you think, Jerome? Is that the problem, or are they being managed by a hepatologist who just refuses to refer to a separate institution?
Yeah, so that's a
Yeah,
I mean, it's in the introduction of the paper we're writing. Because there's no equivalent of dialysis to point at which someone becomes a candidate categorically. I don't think it's possible at a population level specifically to know who's a candidate. But also, I would say that that analysis of who's on dialysis, only 10% of them get referred, that actually misstates, the extent of demand, because many of the people on dialysis are 76. They have an active cancer. They're not a good candidate. We see them in the clinic. Like, last time I was in kidney transplant clinic, I wasn't super impressed by the new referrals. I mean, all of them are pretty borderline, and that's the bottom of the barrel that we're scraping. So I don't think that there's a 90% of all these. I can't imagine there's all these patients who are 25 years old with IgA who've been on dialysis for 3 years who are just not coming forward. I think those patients, from my experience at least, are coming forward, and the 90% who are on dialysis but not coming forward for kidney transplantation are probably not good candidates. So because already 50% of the people who are coming forward are not good candidates. But it is really helpful to have that metric. 90% of people on dialysis are not referred for transplant. So I think it's just a matter of building an argument that there is this great unwashed mass out there that we can never quantify. We just can't get the data to understand what their MELD is at this particular point. What size their HCC was or is, whether their AFP was, so high that they clearly weren't going to be a candidate for transplantation. Whether they had PSC and they were having, recurrent episodes of sepsis, but their physician didn't refer them for whatever reason. I think we just have to accept that there isn't a massive unmet need and we can't quantify it easily, but it's out there. And if we just increase donation, like at every other point in the past, we will see the patients come forward, because we're all very reluctant to not use usable livers. Like, we generally will find someone. It's illustrated by that. Last week we got down to like one patient on the A list, and there was someone in evaluation who wasn't yet listed, and so we just took them. So even if there's no one on the wait list, we'll just find someone if there's a prima facie usable organ. So it's really, donation is the key. All right, I think maybe Santosh, you've got another question?
Yeah, no, I was just being the devil's advocate, and I was just wondering, opening up to the private hospitals and private insurances, would this increase the supply and increase in wait lists?
Yeah, I mean, I think, well, I mean, I'm personally not in favor of that. I mean, the problem is that, and also I'm not in favor of getting an MBS item number for liver transplantation, because, do I really want to be, either myself tempted to check someone's insurance status when we get a liver offer, or be suspicious of my colleague when I look at their choices of the wait list, and sort of go and check on patients' insurance. I don't want to be doing that. But what we should have is a system where something that's so valuable for the people who receive it, because like the quality life adjusted years gained for liver transplant are incredible. It's one of the most transformative treatments out there. Nothing that occurs in oncology could even get close.
To offer patients with liver transplantation. So yeah, I think we just need to state that very clearly. We've got an amazing treatment, and even the low MELD patient argument, like patients of low MELD, patients with MELD of 12, yeah, if you do a liver transplant, they're more likely to be dead in the next 10 months, but they're much more likely to be alive in 10 years' time than someone who's not transplanted. So even the low MELD argument makes no sense. So there's lots of these fallacies in hepatology that have sort of grown up largely in the United States, which has a completely different system and adopted wholeheartedly here. But the one thing that we haven't adopted wholeheartedly was competitive MELD-based listing with multiple centers per jurisdiction, and that's probably where we need to go. And I think they should be public. I don't think that privatizing is going to help. Anyway, I've probably bored everyone. I think anyone who's got any...
Thank you, Jerome and Patrick. Patrick and Charlie, for this wonderful discussion tonight. And I think we are going to have the next meeting next month. I think Emma Tully is going to do the presentation. And thank you all once again.
Thanks, everyone. Thanks, Charlie. Thanks, Pat. See you
Thanks
later.
very much.
Thank you.
Thanks,
Bye.
everybody.
Very, very well presented.
Thank you.
Thanks.